I finished my previous talk showing you that maybe algorithms will save our life, but let's talk seriously what we have now and what could be the future. Again, these are my potential conflicts of interest, and here it's important that you know that I'm co-founder of Athena Tech, that it's a startup working with algorithms to predict prognosis in melanoma, and also Dermavision, that is another startup that has a robot that I will show to you. Okay, these are my conflicts for this talk. Again, people that is giving us funding for research. News in skin imagery. I will talk about dermoscopy, about reflectant confocal microscopy, linear confocal OCT, new total body imaging in 2D and 3D, AI and total body imaging. And then I will explain a little bit about our own experience, the efficacy of all these techniques and efficiency, and also new diagnostic techniques using molecular testing. Dermatoscopes. Now we have many different types of dermatoscopes. It's crazy. I love that. When I started, I had just a Heine, and I should put oil in any lesion. Now we can use fancy things. Okay, fantastic. My suggestion, any kind of dermatoscope, but please use polarized light and cross-polarization. Why? Because then you can see shiny white streaks and rosettes, and both are very important for the differential diagnosis of the tumors. Okay. Because dermoscopy is not just a magnification lens. It's a strategy that allows us to see structures that we cannot see just using magnification. And this strategy is or a liquid and a glass with a similar optical properties than our stratocorneum to avoid the reflection and refraction of the stratocorneum, or we use polarized light and cross-polarization to obtain the same effect. And then we can use more and more magnification to see better some structures. But the majority of dermoscopy has been developed between 10 and 30 magnification. Okay? Even I will show you few things with higher magnification. And dermoscopy is so important because it increases accuracy with training. Of course, without training, not. You can go faster with a car than with a horse, but you need to know how to drive the car. It means it's something that is sometimes criticized, but you need to learn, of course. What is the thing that you can do without learning? It's a stupid question. Of course, improves accuracy, but you need to learn. And for this reason, all of you are here and you are good experts in dermoscopy. But what is new on dermoscopy? The first thing is that we have some dermatoscopes with 3D. And you can see 3D. Oh, is it useful? I don't know. We do not have studies showing that to see the surface, it's useful in diagnosis, but it makes sense. Probably for SCCs, for actinic keratosis, to see the scales, to see the surface, for a melanoma to see it's completely flat or it has an area that is raised. Could be interesting. Now we have dermatoscopes that allow to see 3D. Interesting. And algorithms that obtain the surface. Even more interesting because maybe for our eye, we don't need that. But when we are using algorithms, maybe for the algorithm will be very important to know if the lesion is flat, or if the lesion is elevated, or if the lesion has surface, scales in the surface. Another innovation, high magnification, but not high, super high magnification, 400. With 400 magnification, you can see cells. Every brown dot here, it's a cell. I don't know how to diagnose with this high magnification, but maybe could be useful in the future. Because yeah, I see this and I think, oh, terrible, but it's just a pigment network. You know what I mean? I need to understand, I need to learn. as anything in life. But there are some groups already producing literature, and probably in the future, it will be something else. And easy, much cheaper than a confocal microscopy. It's something that maybe can be used for more people. But let's see to the thing that is really, really, really important. Machine learning algorithms have been applied in dermatology for many years. But in 2017, Stav and co-workers published a paper that they perform at least the same as experts or even better than experts on dermoscopy. And then in the news everywhere, AI is better than dermatologist. We can give up. Go home. Machine is doing the job. In fact, what they did is to train the algorithm with some categories, 7 pre-established categories or 6 or whatever, and then the machine is doing very well, classifying lesions in these categories. It's perfect. You can see for SCCs, carcinomas, melanomas, and with clinical images, with dermoscopy, very good. Then dermatologists can go home. Other studies in Europe, Hansel and co-workers, also compare algorithms with humans. And algorithms are better than the mean of humans. Algorithms better than the mean of humans. Wow, let's go home. But we did also a very important international study. We include lesions from different areas. We include lesions that they cannot be all the lesion in the image because they are larger. We include scars. We include lesions that machines were not trained. And then the performance of machines was going down. For lesions that they never saw before, this is the performance of machines. Very bad. Because humans, we know that we do not know. The lesion in the skull, I was saying, I don't know what it is. I will excise. Machines cannot do that at this moment. Machines don't know that they don't know. And for that lesion, they probably say BCC, because looks like BCC. You know what I mean? This study was very important because now engineers are working to train algorithms to know that they don't know. Let's see when they will win us again. But something that is more important is that we can use algorithms. And when humans use algorithms, we improve our performance. Who improve more is non-experts. Non-experts improve a lot. Experts improve less, but improve. And this is good, because can you imagine that an expert is doing worse because machine is telling you something different? No. Experts, when they are sure, they keep their mind. And when they are not sure, they use the information that is provided by the algorithm. And this is so interesting. And we call that the collaboration between human and computers. We call it augmented intelligence. Because it's the combination. And this is the future for sure. And can you imagine that you have a dermatoscope? There is a video here. Let's see if it's working. Yes. That in any lesion is telling to you nevus, melanoma, BCC, nevus, melanoma, helping you. Wow. Maybe if you are tired and you are going fast to a lesion and the dermatoscope is telling you, pee, go back, it was suspicious. Wow, it could be fantastic, no? This doesn't exist. Doesn't exist. It's just a joke. But can be fantastic, no? What do you think? I love it. I want that. Sorry, but we really have a big problem. And the big problem is that algorithms are doing very bad with really dangerous tumors. They do not recognize Merkel cell carcinoma. They do not recognize a melanotic melanoma. They do not recognize any rare tumor, angiosarcoma, because they need thousands of images. And for the really dangerous tumors, we do not have thousands of images. For this reason, today it's really dangerous, because they will identify many suspicious lesions that they are at the end benign, and they will miss the real killers. Okay? What happens with the apps that people have in the phones? I don't know if they arrive here, probably yes, but in Spain, every week we have a patient that is telling me, my telephone told me that this mall is wrong. And I ask, what is really saying the telephone? No, you need to go to the dermatologist. Okay, I'm the dermatologist. I'm telling you that it's nothing. No, but I'm very worried because the machine is telling me that it's worrisome. Well, the machine is telling go to the dermatologist. I'm the dermatologist. No. And then as the sensitivity should be high, specificity is very low. And it's a nightmare, because if you check these algorithms, in 20 patients in a patient, 10 are suspicious. And it will be a disaster at the end. These are some examples of studies done with different algorithms. And for this reason, now in Europe, we have a task force that is coordinated by Josep Malvé that is trying to put order in all these things and give some specific criteria and type of studies and descriptions that the companies should explain. What are the images that I use to train my algorithm? If all of them are from fair skin adult patients from the trunk, you can apply the algorithm for fair skin adult patients, lesions on the trunk. You know what I mean? Because algorithms are trained with adult images, and then all mothers are very worried about the moles in children. And all congenital nevi are scored as malignant. And it's a disaster. And we need to create better knowledge. Let's move to other imaging techniques. Here, Consulta 11, I'm visiting patients in room number 10, room 11, it's in front of me. And these are the machines that I'm using every day for my patients, okay? Reflectance confocal microscopy, you already know it. It's so fast. Immediately you apply the confocal to the lesions, and immediately you see cellular resolution. It's fantastic. It's great. And we use a lot. It's a non-invasive, real-time, high resolution with cellular resolution. We see images in horizontal plane, a surface of 8 millimeters and a maximum depth to papillary dermis. And you see the stratocorneum, the granulosum, spinosum, dermoepidermal junction with the basal layer, and then with dermal papilla. And you arrive to the reticular dermis. Perfect. Beautiful. Very useful in difficult contexts. Yesterday, I was explaining to you the study that we did with mini melanomas, melanomas less than 4 millimeters in diameter. And 50% of them are invasive melanomas. But we do not excise all lesions less than 4 millimeters. It's crazy. We identify them because they are suspicious on dermoscopy or because they change in the follow-up of our patients, and then we are doing confocal. If confocal is benign, we do not excise. If confocal is suspicious, we excise the lesions. We combine all the technologies. A new amazing technology, linear confocal OCT, allow us 3D cellular resolution in vivo. And you can see here in a melanoma, and let me see if the video is working. Yeah, I think so. I don't know why it's not working. It's not working, this video. Okay, sorry, but in the video it shows all the 3D of the skin. I'm worried if none of them is working. This one is working. Very slowly. I don't know why. I know. Perfect. Now you can see how it's moving, and you can reconstruct and understand dermal papillae, cells in the basal layer, and you can reconstruct. And on the right, you see in yellow an algorithm that identifies melanocytes. It means that now algorithms are applied to these 3D images, identifying cells. And it's something that in the near future, you will have for the diagnosis in vivo at 3D and cellular resolution. Really amazing. Also, they created some algorithms that help you in identifying BCC in the margin. Here is dermoscopy, and you move with the LCOCT in the line that is the margin for the surgery. And in here, you can see the BCC, but maybe you don't know very well how to recognize them. They created an algorithm that you will see the nodules of the BCC in red. You will see now. Let's see if it's working, the video. Yes, now it's working. You see, the algorithm is telling you, be careful, here BCC, here BCC, here BCC. While you are moving with your proof. Yeah, it's not bad what technology can offer us. More interesting things. I never use this. This is a crazy thing. It's a type of diagnosis that is using a laser that you are just with the laser, one shot in the tumor, and then produces a plasma. And this plasma is analyzed with a spectroscopy and analyze all the molecules present in the plasma that you produce with the vaporization of just a dot in the tumor. And according to that, the authors are able to classify tumors. Wow. Of course, my doubts. If I'm doing the laser in an area that is a nevus and it's a melanoma arising in a nevus, what happened? You know what I mean? It's not clear because you cannot do it in 10,000 areas of in the surface. But wow, incredible, no? Maybe also for other type of diagnosis, psoriasis or atopic dermatitis or whatever. If you're doing tuk and then the machine is doing and diagnosis. Wow. Well, it's something that is already in the market, produced in Korea, and some machines already in Germany. Another technology already approved and used a lot in United States. It's a tape stripping. I participated in the studies more than 10 years ago, nearly 20 years ago. And with this tape stripping, they analyze genes, expression, RNA. And with the detection of the expression of link and PRAME and mutations in TERT, in 5 days, they tell you if it's melanoma or not, with a negative predictive value of 99%. Wow. But of course, you need to know where to apply the scotch. And the cost, I think, is $3,000. Wow. It's a lot. It's crazy. I don't know how they manage, but they are doing that. And it's very fancy. They are using a lot that. Let's move to another technology, because in which of these lesions I apply my scotch? You know what I mean? It's very fancy for one lesion, but patients have many lesions, and we need other technologies to deal with them. Now we have this 3D technology at our institution, and I will explain to you a little better what we are doing. First thing, it's extremely important to know which patients benefit for total body photography. Should be patients at high risk, many moles, previous history of melanoma, previous history of familial melanoma, multiple primary melanoma, or carriers of mutations in genes of high susceptibility to melanoma. It doesn't make sense to put in the machine today all the population because it's not cost effective. Okay. We published many years ago, more than 20 years ago, the combination of total body photography and digital dermoscopy. And yesterday I explained to you how efficient we are with this combination, the two-step method for follow-up of high-risk patients. And I explained to you that 30% of the lesions were excised because changes in total body photography, and 70% of the lesions were excised because changes in dermoscopy. And from all the melanomas that we excise, 40% were diagnosed because changes in the total body imaging, and 60% because changes in dermoscopy. We excise a mean of less than 2 lesions in a mean of 8 years in these very high-risk patients. And we diagnose melanomas in 12% of them. Very efficient. Very few lesions excised. Very efficient. This is what we use at that time, but now we have new equipments for total body photography with 2D high resolution. They are incredible. They use also polarized light. This is normal light and polarized light. You see that it's not shiny anymore, the skin, and you can see better all the lesions. And also with high magnification of the body map, you can see globules. Wow, impressive. They are so good, but they cannot substitute dermoscopy, okay? We are using also this machine that is the 3D, and the patient is 1 second there, one shot, and the machine reconstructs the 3D. The machine needs 5 to 7 minutes to do the reconstruction, but then the machine also extracts all the moles and is doing the calculations and applying algorithms, etc., etc., etc. And you see the quality of the image in total body mapping is not bad. It's not bad. But it's not true that with total body photography in 2D or 3D is the same resolution as dermoscopy. It's not true, and we demonstrate it. What we did is to use this sticker, that is what industry is using to analyze resolution. And we apply the sticker in different areas of the body. And we obtain images with 2D and with 3D, high resolution 2D, high resolution 3D. And what we saw is that the resolution in head and neck, 2D, it's better than 3D, okay? And for other parts of the body, the trunk and extremities, for the trunk, it's similar. This is with Vectra, and they are similar, okay? But for the facial lesions, the resolution is better with the 2D. But when we compare resolution, the resolution of total body photography 2D is 2.18, 3D is 2.04, no statistical difference between them, except for facial areas, but dermoscopy has a resolution much higher, it's 14.3. Okay? Then total body photography cannot substitute dermoscopy. Even the resolution is good. And this is the image with polarized dermoscopy and 3D, polarized dermoscopy and 2D. It's blur. It's the same lesion, of course, you can recognize. Maybe if the hyperpigmentation appear, you can see that the hyperpigmentation appear, but you do not see the criteria. Okay. Pros for 3D. Timing, that is few seconds. Patient doesn't need to be standing up naked for 5 minutes. Avatars with better representation of complex body size. You can see the axilla, you can see the area here, everywhere. You can see much better with 3D compared to 2D. But the problems, cost, and you need space to have this big machine, and you need to be organized. Let's see how it's working. In this, it's a comparison before and after 6 months. Any changes? Do you see any changes in this mole? Yeah? You see them. It's growing a little bit and it's changing pigmentation. You're right. When we calculate it, it's growing. Okay? It's growing and it's changing this area. This is a dermoscopy of this lesion. It's very suspicious, but in the context of the patient, it was not considered. Then also the machine has an algorithm analyzing dermoscopic images and is telling me this lesion is suspicious. You need to excise. Okay? In this patient, the algorithm extracts 500 moles, and the algorithm can compare. And in blue, lesions growing, and in yellow, lesions that are losing pigmentation, and also for the lesions with dermoscopy, giving you the score. All of these are artificial intelligence algorithms helping us in our clinical practice. And you can see all the lesions during follow-up and the comparison of other lesions. Just examples, suspicious lesions, and confirmed melanoma Breslow thickness 0.2. Even with patients with xeroderma pigmentosum, we follow 14 patients with xeroderma pigmentosum. I know that you here in Morocco have 10 times more incidents than we have. In Spain, it's 1 per million, and for you, I think it's 1 every 100,000 inhabitants or more. It means that really difficult. For us, this machine reduced the time of exploration for these patients a lot. Because help me to identify changing lesions, because I can compare body maps, because the machine is helping me. And in this case, more than 3,000 lesions were extracted. And when a lesion is changing, we are doing confocal microscopy, and with the confocal we confirm it's banal or it's suspicious, and we excise. This is our experience. We incorporate this technology in July 2021, and we closed the analysis. We're still using, but we closed this analysis in December 2023. We included 1,300 patients, 1,313 patients, 48% men, 52% women. We obtained nearly 4,000 3D total body maps and a mean of 3 maps per patient. What we obtain in this period of time is a number needed to treat of 0.9 per malignant lesion. The ratio malignant benign is 1:1. And the ratio melanoma nevus is 1 to 1.6. Not only with Vectra, dermoscopy, confocal, you know what I mean? We use everything. When a lesion is changing, we analyze dermoscopy. When we think it's suspicious, we are doing confocal. And we excise, as you can see here, it's 70... Yeah, 75 or I don't know, melanomas. From them, in situ, 40, sorry, because I don't see the number, might be 46 in situ, and in all the lesions that we excise, and 31 invasive melanomas. Also, we excise 88 BCCs and 15 SCCs that we saw during follow-up of our patients, because it is more dedicated for total body photography for high-risk patients for melanoma. And the mean breast lobe thickness was 0.82. But of course, we have patients that we identify these suspicious lesions as the first visit, and then at the first visit, the breast lobe thickness was thicker, but in the follow-up, the breast lobe thickness was thinner, okay? It means that it's quite efficient. Something that is interesting is to see if it is reproducible. And Peter Sawyer group count the nevus in the patients and compare with the counting of the machine. And it is reproducible, and it is a correlation between human and machine counting of the moles. And this is good. Also, other authors compare 2D with 3D. And what they saw is that these are the melanomas that were diagnosed for both 2D and 3D. Those are the melanomas that are diagnosed by 3D, but not by 2D. And these are the melanoma, the contrary, 2D and not 3D. It means 3D was missing one melanoma. And this is the melanomas that are identified by 3D and not 2D. It means 3 melanomas. I will explain to you again. In this study, they compare the melanomas that can be identified by the doctor using technology, all of here. And these in black are the melanomas that one of the two technologies are missing. Okay? Then it means that probably 3D could be more sensitive than 2D because some areas can be hidden. It's just one study. We need more studies in the future. This is another study in which they are trying to establish the number of melanomas diagnosed, but still very, very preliminary. New technology, my conflict of interest. It's a robot that is taking autonomously. The robot is speaking to the patient, and with these screens that you see here, explaining what is the position, and what is doing the robot is total body dermoscopy. Dermoscopy images of all the lesions from the distance. It needs between 5 to 7 minutes. And I will show to you the resolution of the images. This one is with the machine, and this one is the real dermoscopy. Not bad. Not bad. It's so good. Okay? Then maybe in the future, we can have these machines everywhere, and we can be in a central place looking at the dermoscopy of everyone. Okay, in conclusion, imaging techniques in dermatology increase diagnostic accuracy, decrease the necessary excisions, identifying difficult to diagnose melanomas. AI applications allow the development of 3D avatars, identification of changes, and analysis of lesions and or suspicious areas, and the incorporation of new diagnostic molecular technology is a new challenge. And with that, thank you very much for your attention.